was very impressed by the acronym of the Neighborhood Health Station. Does that spell out NHS?
Well, that wasn't how it was intended, but we understand.
Doesn't that make it NHS? Is that what you're trying? That's the real that's the underlying.
Just a gentle hint.
Yeah, a little gentle hint there. How many here have seen the movie Escape Fire? Okay,
Yeah.
so that's something we use in our educational systems for medical students. Early on, I teach not only at Georgetown, UCI, but also Johns Hopkins, and they show that movie there. And I thought of that because I noticed you had Loan Institute down on the bottom of your slides. And Sharon Brownlee is in that movie, and she's one of the co-directors of the Loan Institute. And she has this phrase in that movie. The narrator, by the way, or one of the main narrators, or at least the introduction, is Dawn Berwick, who also I think gets this. But she has a little phrase in there that says our health care system is perfectly designed to keep you sick, but not let you die. Because that's exactly where it makes its money, right? If you're not sick, then we don't have anything to do with you, right? But if you're dead, we don't have anything to do with you either. So you got to keep in that sweet spot. And I think that's just, apropos to these areas. Pardon me with the phrases. So I wish I had known about neighborhood health centers, because after that movie came out, we did something with Dawn Berwick and a number of other legislators, including Barbara Mikulski, Harkin, and a variety of others who at the time were instrumental in moving components of ACA through and called Wellbeing in the Nation. And it was an attempt to look at how would you create a social infrastructure for tapping into the social resources that exist within communities to create well-being, create health in those areas. And we were, the fundamental idea that was inherent in that was using something like the Agricultural Extension Service, which is one of the most successful government efforts in terms of ROI and in terms of productivity, even in terms of many health areas, to facilitate. It was focused on facilitating, food production and farmers and agricultural work, but it connected the universities, the state universities, with community services that then supported individuals in basically getting together and learning how to work together. So the idea was that we put in place an infrastructure of things that could build things like neighborhood health centers, okay, from the community, and we're not actually led by the physicians. I mean, it was led by a community development process. Many of the models were drawn from community development, wrote white papers about that. A lot of those examples came from overseas where those successful models have occurred. And that was actually supposed to go into the first 100 days of the administration. That didn't happen. We'll leave it there. What I'd like to do is I'd like to sort of build a little bit on what I talked about this morning and several other things in there, is to talk about how do physicians actually and how do health providers sort of begin to get into the transaction component around health. And I indicated to you, as you all know, that it meant coming out of here, coming out of the box at the top, and now actually asking questions in the day-to-day practice where the determinants of health are. And I call those personal determinants of health. It includes behavior, it includes social, it includes environment, which is another thing we haven't talked about. And we describe that as integrative health. It's not the same of complementary medicine practices. It's not the same of integrated medical practices. It's not just lifestyle medicine, although we've heard a lot about that. It really is the integration and doing that within the context, of the cultural context of the social determinants that exist for those areas. So how do you actually change that conversation? And I'm interested in this as an approach, because I think this is something that every family doc can do. And in the residencies I teach in, the medical students I teach in, I do a course at Hopkins, for example, that introduces folks to integrative health. And these first-year medical students go out where they're supposed to get clinical encounters, and we require that they actually do a hope note when they're out there. And it's fascinating to see what they come back with in terms of, oh yeah, I asked this question and here's what the person said. And I asked about what was important in their life and they had that. And then my mentor said, why are you asking those questions? And we can't, and it showed that in fact the underlying determinants of were not being addressed in the clinical encounter that was going on there. And the students saw that immediately, not only abstractly, but in their actual first line. This is before they actually get into the main part of medicine. And it involves basically asking what matters, as you've heard here in terms of the whole health visit. There's lots of different models, and this is part of what's confusing. People say, well, what is a whole person in those areas? If Maslow's hierarchy, and then there's the circle that you saw from the well-being, the whole health from the, and there's a number of others that you all had in those areas. I think we got to keep it pretty simple: mind, body, spirit, right? Mind, body, spirit. But then that has to be concrete. Means, well, what do we mean when we ask things about spirit, about the mental and spiritual? What does that mean? What questions actually get at that? If you're going to begin to have a conversation with somebody about their spirit, some places you can't even use that word, okay? Because it is interpreted differently. Social and emotional, a little bit easier, except for those that don't want to go there. So how do you ask about social support in a way that's not threatening? How do you ask about ACEs, about adverse experiences that contribute a good chunk to many chronic illnesses we know now? Behavior and lifestyle, I think people get that. They understand that about the physical environment, how we're exposed day to day to what's happening around us and how that interacts with our neurological system. Most people are not aware of. So I mentioned that there was a toolkit on my website, and I'm just going to show you a couple things. So this is how you basically do a hope visit. So first there's a preparation phase, then there is an actually interaction, a conversation phase with, if they're patients you've seen before and you've prepared them, you can do it in 30 minutes. I've done it in less than that, okay, but 30 minutes is probably necessary. An hour if you don't know, and you've got to look at all the medical stuff first in those areas. The personal health, give them a personal health inventory. This changes the conversation in 5 minutes. In fact, you don't even have to do it ahead of time, although it's ideal to have them do it ahead of time and then bring it in, because then they think about it a little bit. I've given this to patients 5 minutes before I brought them in. And they go down and they just scribble something on it, and you know what? It changes the conversation. Because now they know I'm going to be asking questions about, why do they get up in the morning? Okay, I had one guy that came in a few weeks ago, and he literally gotten it 5 minutes before I walked out to get him. And he walked in, and he says, what do you live for? That's one of the questions. What's the most important thing? And he said, my cat and my wife. And that allowed us to talk about why the cat was important. Okay, why was the cat on there? And what was the order of those compared? And this really opened the conversation for him. Okay, the medical student had already come in and presented all these things, and they were changing him from, to Cymbalta and all this kind of new medications. And he said, this guy was really injured. I mean, he was psychologically injured. Multiple visits, lots of utilization, lots of chronic pain on opioids. His fundamental question was, he'd never told anybody, he said, my cousin started doing CBD oil, and man, his pain improved and he felt so much better. Can I get some of that? That's what he wanted to know. And we opened up that conversation. We just didn't say, okay, it's illegal, it's whatever. It's not illegal, but it's like, how do you get it? Where is it? What's the quality? And we had conversations about that component of that. He began that conversation and he said, oh, I understand that you have a group that talks about that. This was a veteran. This guy had pretty severe PTSD. His wife and his cat were the only social support he had. Towards the end of the visit, I asked him, wait a minute, I'm going ahead of myself here. Okay, know the domains of health. I'll finish this story in a minute. The personal health inventory is what opens those up. Easy to do. I think you have copies of our variation of that. The VA one is a little bit different, okay, than what you have. Again, I'm trying to use this in a more, a different kind of environment. What are the 5 domains? There's basically 5 domains that you ask people about, and there's only a couple questions in each one, and then have your CPT codes ready. And if you need to know how to do that, ask Scott over here, okay? We have a list of things on our website, a little toolkit that is trying to get at how do you do this. But Scott, you made it look so easy up here. I think most providers actually, it's not that easy for them. They need the kind of assistance that you're talking about to do business in those areas. So the personal health inventory in the visits, make sure they come in with that, okay? They're holding it in their hand, they hand it to you, you read it with them, okay? Very easy to do. Then the hope questions, keep it fluid. Don't make this a checklist. If this becomes a checklist, you're dead in the water, okay? You actually don't have to ask all the questions that are on there. If you do, it will take you 2 hours to do it. What you're trying to do is you're trying to get down to the core of what matters to that individual, and then how does that connect to other things they're willing to do. Once you hit that, you're done. You're ready. Go with that, okay, in those areas. That may come out of the first question, and it may come out of any of the domains I'm going to show you here, the physical, the emotional, the behavioral, in those areas. The AMA has a very nice health coaching model that I think is useful in the visit itself. It's called Ask, Tell, Ask, Action Plan, Closing the Loop. There's various ways of modifying that. Reflect back and listen is another approach, but it basically means listen. Okay? What did the person say? They will always tell you what you want to hear or what they think you want to hear. You know this, okay? The most poorly compliant, and yes, I still use that term, patients are some of the ones I love the best. They come in, you're such a great doc, okay? You know, you'd help me so much, etc. And then you find out they didn't even refill the prescription that you did. They're going to tell you what you want. This is why, you know, this builds in sort of the reporting bias that we contact in those areas. So you really have to listen to their body language, okay? Oh yeah, I'd like to do diet. Well, how is your diet? Okay. Oh, it's okay. It's fine. Okay. And yeah, I'd like to do something in the area of diet. And then they go off and talk about your cat. Okay. You know what? They don't want to do their diet. Okay. It doesn't matter what they say. Okay. It's not high on the priority list. So you do this by, you know, reflection and then hand it off to some other tool. We've heard lots of tools. I hand it off to a medical assistant who's got training as a health coach that then can plug them in and assist them into those processes, but there's lots of other tools in those areas. Okay, personal health inventory, I already talked about that. Why do you want to be healthy? What's the most important thing in your life? Okay, those fundamentally say, you know, what do you do when you get up in the morning? Okay, had a guy with 20 years of back pain the other day, and I asked him this question: what would you do if you didn't have back pain? He immediately, this guy had been through 2 surgeries, injections, the whole stuff that I showed you Sally had, but even more. And he immediately knew. And he said, well, if I didn't have back pain, I'd get in my car and I'd drive 5 hours down to where my grandkids live, and I'd get on the floor and play with them. That's the most important thing in my life. I said, great. Marched him over to the physical therapist, and I said, he wants to get up and down the floor. You work with him until he can do that. Okay? It's gonna hurt. Okay? I'm not here to solve your pain problem. I'm here to help you with what you said you wanted to do, okay? Now, he's got to do it, right? And he did. He got up. He went back into the physical therapist a couple times a week. He did the exercises at home. It hurt like hell, but he kept doing it. And in about 3 weeks, he called me up and he said, I just got in the car, drove 5 hours, and got on the floor playing with my grandkids. He's hooked, okay? He keeps doing those exercises. In about 3 months, his pain levels are significantly down, okay? Hooking it up to what matters. Single question. I didn't need to ask him about all the other lifestyle-based stuff. That's what he needed at the time, okay? Here's the domains. Listen to what matters. Explore what happens. The personal determinants of health. It's either on the behavioral or the social side. It's in one of these areas, okay? So spiritual and mental, we talked a little bit about that. What matters. Desires, belief, and hope. Why they get up in the morning, what their purpose in life. Those are the 2 questions we've already talked about now. Behavior and lifestyle. It's a little more complicated because people have gotten sophisticated around this, okay? Basically, diet, sleep, stress, and activities limits. So what you're moving, when you're not moving, what are you eating, and how do you manage your stress? They will tell you what their diet is just by asking them, well, how's your diet? Everybody kind of has heard about what you should be eating more healthily. And they'll usually say, oh, it's great. Or it's okay. Or it sucks. They'll tell you that. And then all I do is say, well, what did you have for breakfast, lunch, and dinner last night? And count the fruits and vegetables. Okay? And do that in 5 minutes. They will tell you, and the way they do their body language tells you whether they're doing it or not in those areas. It is so, they're transparent in these areas. You don't have, I mean, you can do a full dietary frequency if a diet is a major issue and they want to go there, it's the path they want to enter into healing, then you can do a more detailed dietary analysis in those areas. But don't do that if they're not going to want to do it, because that's not where you want to enter in. They may tell you something else. How's your sleep? They'll tell you that. How's your stress is the wrong question. You might ask them that if you want, but it's the wrong question. The question is, what do you do for stress management? Okay? Just assume they're under stress, okay? And whether they perceive it or not, everybody has stress. I hope they do. It keeps us going, right? You need a little bit of stress in those areas. Ask them what they do for stress management. In my practice, most of them will say they exercise, okay? Or they read books, or something like that. That gets into the conversation that stress management is not about stress. It's about balancing the autonomic nervous system, okay? It's about, is your sympathetic system on all the time and your parasympathetic system suppressed, which is where the healing actually comes in, and the recovery and the cleansing and that kind of stuff. How do we balance that back? It's mental fitness. You go and exercise to keep physical fitness. You can't go pick up the trash can if you haven't, have at least a few muscles there that you've been exercising. It's the same thing. It's mental fitness. And you can show them the MRI scans that show if you practice some type of relaxation response, regardless of whether you're stressed or not, for 20 minutes, for 8 weeks, you will grow the left frontal temporal lobe and can actually manage your hippocampus and your amygdala, the fighter, the panic button in the brain much, much better. If you haven't done that. So ask them that area, activity levels, etc. Do they believe it's helping them? Very important, okay? If they don't believe what they're doing is helping them, then you've gutted one of the core components of the placebo effect, which actually contributes a good 70 to 80%. If you don't believe this, most people believe it in drugs because they see the placebo effect in the double-blind drug trials, but people don't realize this happens even more so in behavior and lifestyle. If you don't believe that, look at the studies of the Stanford researcher Elia Crum. Okay? In my book, I tell a number of her stories, including one called Mind Over Milkshakes, which is an elegant study showing that the rise in the hormone that allows you to feel satiated so you don't eat more actually has mostly to do with what you think you're eating. Sorry, Joe. But double-blind studies in which you give somebody the Indulge shake, high fat, high calories, high sugar, etc., or the Sensa shake, low fat, healthy, etc., etc. They drink one of those shakes, you measure their satiation level, you measure their adrenaline levels, etc., 3 times higher if they drink the Indulge shake. They're the exact same shake. Okay? They're the exact same shake. The mind interacts with our food in a way in which we turn the Mediterranean genes on before we ever take a bite of the Mediterranean diet. Okay? If there's a social interaction involved with it. The social emotion gets you into the social emotion. Here's the 2 questions I ask. I usually don't need to ask anything else besides this. Okay? How's your social support? They will tell you. Okay? That's okay. And what do you mean by that? Okay, I'm sorry, I'm going to do real gender bias here, but I've seen it over and over again. The men, often it's the spouse. That's what and that's enough for them. They say, I feel okay with that. Okay? Until something happens there, and then they're not okay with it, right? Women, friends, family, everybody, church, community, work colleagues, they get their social support in some place. If they don't, then they suffer from one of the major epidemics in the country, and Jeff Geller's here actually runs group visits disguised as healthcare visits, but that address that fundamental salutogenic component, which is social support and loneliness. I'll ask them what their childhood is. The guy with the cat, okay? He came in and I said, a lot of people with chronic pain and that kind of stuff, they've often had some pretty tough things go on in their childhood. And how was your childhood? Okay? He looked at me And then he looked over at the resident and he said, would you mind leaving? To the resident, okay? I said, okay. Resident walks out of the room. He said, it sucked, okay? I was sexually abused starting at 7 years old, okay, as a guy, all right? Until I was about 14. I was then put into another foster home, taken away from my parents, etc. It freaking sucked, okay? And I said, you know what? That's important. Let's figure out how to deal with that. He said, I can't do it right now. I said, fine, we'll put it in the parking lot, but it's there. At some point, we'll be able to address that. The VA has that kind of thing happening all the time, and they have then mental health, usually another veteran who says, come to me with a group, okay? We had a social group, a focus group at one of the VAs we were visiting recently, and the guy said, I was suicidal, and yoga saved my life. Now, so yoga is not a treatment for suicide, I don't think. Is it a double-blind study showing that yoga helps with suicide? I don't think so. I said, what do you mean by that? And he said, a buddy of mine said, come to this yoga class. And I went to it and I liked it. It's pretty cool. Warrior yoga, okay? And it did away with his loneliness. He found a social support group in that, and now he doesn't think about suicide anymore when he thought about it every single day before that. Yoga literally did save his life, okay? The quality, the depth, is much more important than the quantity, okay? It's not how many friends you have, it's do you have somebody that you feel safe with, that you can trust, that you can connect. And it's pretty easy actually to tell with that. You can ask them questions like, do you have somebody, if you really needed to call on them tomorrow because you had an emergency or had to go to the airport or whatever, who would you do? You got somebody immediately. If it doesn't come to mind, then they don't have somebody that can do that. The physical environment is very important. I told you the story about Sally this morning that didn't have a place. What's your home like? What's your work like? Exposure to nature. If you look at the data on what it does to our neurological system, we grossly underestimate the value of being exposed to nature. Just simply getting outside for a weekend in a retreat-like setting will bump up your natural killer cells by 40% for 2 weeks, single time like that. The biology is actually there, so we ask about whether they have that. The social determinants, okay? Huge area, and what we've given you is a hope note, set of questions, and then there's a social determinants supplement on the back. Robert Wood Johnson and others have said this is about 40 to 50% in the nation of population health drivers in those areas. So if those are issues, education, employment, safety, exposure to violence, food insecurity, etc., then those are going to either prevent or enable people to engage in the behaviors. But I'll tell you, I've seen people who've had every one of these things, and yet they've changed their behavior. They've been able to get empowered and change their behavior when you hook it to something that's really meaningful. And we've heard a couple stories like that in those areas. So then, summarize it and agree. This is the feedback loop that Bitsy was telling us about, okay, in this area. And there's Thomas Bodenheimer's health coach model, in which he actually has that summary in that. And then I set up a personalized health plan in the same visit, goes into the note. What am I going to do for him today, right now? And I might bring in the health coach, I might bring in the battlefield acupuncture person, I might do, something that I'm going to do today so that they know they're getting something. This is the power of taking a pill, right? I'm going to give it to you now, and you're going to take it. And if it's a placebo and you take 4 of them, you'll do better than if you take 1 of them. What's going to happen in the next 2 weeks? The primary behavior change, which is a personalized health plan. That takes a little while to kind of develop. You may have come up with your initial list in the office, but then it has to be worked with either the health coach or some of the other assistants or you, if necessary, within 2 weeks to say, is this really what you want to do? And out of that then comes the SMART goals, where they need success in at least one of those things. And success builds on success if they can actually show and measure those components. And then within the next 3 months, you want to actually have them accomplish one of their primary SMART goals in those areas. Okay, so I won't go into this. This is all the ways that this can assist. Okay, we've heard actually a bunch about those, and we can add a number of other things that we've heard from this how do you get it paid for? Here's my list of of the codes you use to get it paid for. But I've talked to Scott, I'm sure he's got a much better way to do this. We are putting on and are looking for examples of toolkits because this is the number one question I get from physicians and in clinics is that how do I pay for this? And there are ways to do it. Physicians in clinics are usually notoriously bad at figuring out how to do this. They leave stuff on the table, and as we've heard, there's so much waste. The rounding error can actually be pretty significant in these areas. Okay. I'll just mention a little bit about the Learning Collaborative, although I think maybe we're going to talk about that a little bit later today. And tomorrow at 2:30, for those that want to take any of the ideas that we've had here and perhaps create a learning collaborative where that can be these things can be implemented into your own practices, your own residency,